So our first presenter is Dr. Michael Boros. Dr. Boros is a vascular surgeon at Munson Medical Center in Traverse City, and he's going to talk to us today about limb ischemia.
All right, great.
Thank you.
Yeah, so good morning. We're just going to do like a really brief kind of summary of limb ischemia. Do I have it or not? All right, I'm trying.
I'll click the down arrow on your computer. Or maybe the up arrow. There we go.
There we go. Oh, now it's going to go crazy. Really delayed.
Yes.
Would it be easier if you just did it?
I can.
Yeah, go for it.
Okay.
So go back a couple slides.
Okay.
There you go.
There we go.
So the next slide. Yeah. So there are objective and subjective criteria to this, which is probably why it can be confusing on sometimes. But essentially, we're just going to talk about the three things: acute, chronic, and then acute on chronic. So yeah, next slide. So acute is essentially how I describe it as like someone being choked. So it's like a sudden stoppage of the artery supply. So that's essentially no oxygen to the tissues distal to wherever it's blocked. And besides like trauma and things like that, the two big reasons in our world is usually an embolism or a thrombosis. And then you'll hear things like the classic like 6 Ps, and we'll go through those. But essentially in this scenario, like emergent therapy is what we're looking at that we need to do. Next slide. So as far as embolism goes, the big ones are cardiac and non-cardiac. So someone in AFib stays in AFib, the blood clots in the atrium, and then they go back into a normal rhythm, and then it kicks the clot out into the periphery. Paradoxal is pretty rare. Paradoxal is where you would actually have a venous clot, and then you have like a patent form of valve in your heart, so it goes from the venous to the arterial, and then it gets shot out. You can get vegetations and clots like on valves, which can then get released from the valve out into the arterial system. That's like an IV drug users, people that have like chronic lines, like central venous catheters or even arterial catheters. And then in immunocompromised patients, we can see that. And then one of the rare tumors, an atrial can cause this clotting and shoot out into the periphery and cause ischemia. That's why you might see or hear like sometimes when we do our procedures and get the clot out, like we'll send the clot to pathology because that like we're worried that could be an atrial myxoma. As far as non-cardiac goes, like you'll hear things like shaggy aorta or calcified big blood vessels where clot can attach and then detach and then go into the periphery and cause issues like atheroembolism is what that is. And then these mural lesions on specifically the aorta, like ulcerations where clot can be released and then get pulled down into the periphery and stop wherever the size of the clot is bigger than the size of the artery. Next slide. And then the opposite of that, thrombosis, that's, we got arteries get hardened, you get an atherosclerotic narrowing, and then it eventually clots off and causes acute ischemia. You can have someone that is hypercoagulable. Frequently, patients with cancers can have arterial clots from a hypercoagulable state. Rarely is it vasospasm like Raynaud's. That's more not a surgical intervention, and it's usually not acute. I mean, they get the sensation from that, but it's usually not in the surgical realm. Dissection, so actually a separation of the blood vessel wall, where it tears and the blood flows in between the layers of the wall, and then that can shut down the artery. And then occlusion of a bypass graft, which is usually related to one of the other issues. It's usually not the bypass that's the problem. It's usually like where it's attached is where disease will build up and then shut down the bypass. Next slide. And then we alluded to those 6 Ps as kind of like the classic teaching of acute ischemia. So they'll have a lot of pain, a lot of acute pain. The tissue will look white. They won't be able to move it. You can't feel a pulse, and in this case, probably can't even hear a Doppler signal. They won't be able to feel it. And then that poikothermia is always like the trick word, but it's essentially like a cold state, like a cold-blooded animal. So the limb will be cold-blooded at that time. Next slide. And then classifications, like the classic classifications in this scenario would be that if it's viable, threatened, or it's irreversible and damaged. So viable usually it's not like immediately there's a problem, but it's still a problem that you have to get to urgently to save the tissue before it becomes threatened or irreversible. Threatened is when more of those classic P's come out. So they'll like lose sensory, usually distally. So like in this case, if it's a leg, they would start losing sensation in their toes. If it gets really worse, it can be up the leg, and which elevates the problem. So they break those down between marginal and immediate. So marginal is where it's like just starting to happen, whereas immediate would like be the whole leg. Both of those, I would say, need prompt treatment, immediate treatment, and basically you want to get to the OR to take care of the problem as soon as you can. And then irreversible, like the tissue is gone, I mean it's dead, and even if you got blood flow to it, it wouldn't save it. In those cases, like you'll see like you can see dry gangrene or wet gangrene, but they can't feel it or remove it at that point. Next slide. And then what we do as far as treatment, usually the first thing is to thin the blood. So we put them on a heparin drip and then get them to the operating room. And that's where the options become apparent at that point. A true open operation would be opening up where the blockage is. In this case, like an embolism. So you do an embolectomy where we use these Fogarty catheters to remove the clot. If it's hardening of the artery and it's slowly shutting down, would be to open up that artery, get the clot out, but also get out the hardening of the artery, open the artery up. If that's not possible, then you go around the area to where there's good blood flow to where you can get to where there's good blood flow outwards, so bypassing the area. In an endovascular realm, there's mechanical and chemical thromboembolectomies. So chemical is like TPA, mechanical is more like you'll hear things like jet stream and things like those catheters that go in and kind of actually suck out the clot, or use like physics principles to essentially get the clot out through a catheter. In ECOS catheter is another thing you might hear about. That's an ultrasonic catheter where you place the catheter through the clot. It emits ultrasonic waves to help open up the clot, but also disperses drug, TPA, to open up the clot. Next slide. Now we're going to flip to chronic. We're going to skip acute on chronic. So chronic, like the classic teaching is this is the most common cause of walking disability that we see as vascular surgeons. And essentially there's 5 groups, like subjectively. I always kind of talk to patients about this. They have the disease and don't know it. That's the asymptomatic. Those people we usually don't see. And then when you walk, you get cramps, but you can still kind of live your life. That would kind of be mild claudication. Severe claudication is you walk, you get cramps, but it's messing up your life. Like the classic example, which is getting pretty dated now, is like the mailman that can't walk and do his route. Rest pain would be those cramps with doing nothing. And then the most severe would be you're already showing signs of tissue loss, like a black toe, ischemic, gangrenous toe. That's the subjective nature. And then there's also other classifications, and we'll go through one of the classic ones, is the Rutherford classification. So next slide. So Rutherford kind of breaks this down a little more. And you might see this in our documentation, like to level or kind of classify the people so we know who to treat, who not to treat, or why we're treating. So they just kind of add more, not more specific, but more subjective natures to it. So 0 is asymptomatic, 1 is mild claudication, 2 is moderate, 3 is severe, 4 is that rest pain, and then 5 would be tissue loss, like minor would be a toe, whereas major would be maybe a foot. So some subjective nature to this. but it just kind of helps us classify the people to know how severe their disease is based on their symptoms. Next slide. So risk factors with atherosclerosis or vascular disease. This is an elderly disease. We usually don't see this in pediatrics or kids. Usually race is related, like non-Hispanic blacks have a higher risk factor. Males versus females, diabetics, smoking, of course, the hypercoagulable patients, hypertension, and lipid disorders. So just kind of generalized things that put people at risk for chronic ischemia, chronic vascular disease. Next slide. And then an objective measure that we do classically is the ankle brachial index, which is essentially just blood pressure cuff on your arm versus a blood pressure cuff on your leg. And it ranges basically from 0 to 1.4. I guess it could be higher than that. When it gets over 1.4, that's basically a non-diagnostic test, meaning the arteries are circumferentially calcified where compression of that artery is too difficult to get an accurate blood pressure. So that would be a sign of atherosclerosis, but also like medial calcinosis, which is hardening of the arteries. So this test probably isn't the best of being more specific, but it gives you a clue that yes, they have the issue. So between 1 and 1.4, we would say that's normal. Anything below 1 is abnormal. In this instance, like the reference that we use, which was the Rutherford book for this whole presentation, actually. Anything from 0.9 to 0.99, they say is borderline, and then 0.9 is they classify as abnormal. There are more specific classifications of this too, but they're all subjective where they're using these numbers. I always kind of tell patients like this number is not that great for one shot in time. It's more of a trend. So if we can see like their ABIs staying the same, I would say that's good. ABIs that are decreasing, that just means the disease is kind of catching up to them. So this is just one measure that kind of helps us in our pathway of decision making, who needs a procedure, who we manage medically, who we recommend exercise, all those kind of different things. Next slide. Task classification is another one that you may see. This is more procedure specific, I would say. It would fill up like this whole screen of tiny little writing. So I didn't like actually take a picture of it just to give you an idea. It's basically just a group of specialists got together. That it was the Transatlantic Inter-Society Consensus, and basically looked at two areas. The first time they looked at it was basically aortoiliac lesions. And then the second time they looked at it was femoral popliteal lesions, and basically broke them down between A, B, C, and D. And it's just the severity of where the stenosis is or the disease is. So A is more of a medical management, pushing and endovascular management. B, the recommendation is endovascular. C, the recommendation would be endovascular or surgery. D would be surgery. And I think this is, again, there is a subjective nature to this as in choosing the modality of treatment, in that a lot of technologies happened since this first occurred. And now you'll hear things where, A through D could be treated endovascularly, and you'll have two sides of that argument. I think it's like anything with what these kind of things that we talk about, where like endovascular specialists will argue for them, open surgeons will argue for that, but it's basically just a measure of the disease, of where it is. And at the time they made the recommendations, that's the modality of treatment they recommended, not necessarily what we would necessarily do today. Everything's kind of patient specific. So next slide. So then for the chronic ischemia therapies, again, so same thing, medical, surgical, or endovascular. Medical is where we get into the like smoking cessation, good diabetic management, the antiplatelets, and the statins that we focus on for this collaborative. As far as surgery, endarterectomy, where we would open up the artery and take out the disease. Bypass is where we would go around it. And then from inside of us, the vascular management, there's all sorts of modalities, different types of balloons, different types of stents, atherectomy devices, which the patients like to call rotor-rooters. And then there's combinations of the two, bypass with a balloon or bypass with a stent. So hybrid procedures is not an uncommon thing as well. Next slide. And then acute on chronic, there's no like classifications or anything specific like that. It's essentially just like everything in between. So yeah, like classic one would be we have a known patient that we know about, but then comes in with signs and symptoms of acute ischemia. So we know they have chronic disease, but they're coming in and it's an acute problem. Like we got to deal with it sooner than later or immediately. The good part about that is just anecdotally, those patients usually have a better tolerance to like true ischemia because they're kind of in a chronic ischemic state. But that leads into down the line where, they've already had procedures. So it could be a complication from a previous procedure, like a stent went down or a bypass graft is narrowed. So it kind of opens the door to more than just like blood clots from the heart, simple things like that. And as far as treatments, like everything goes. I mean, all the things that were listed for acute, all the things that were listed for chronic, to basically get on top of the ischemia and make sure we can salvage the limb.